Good afternoon, ladies and gentlemen. Chairman, I am a pediatric radiologist. I work as a pediatric radiologist in Helsinki University Hospital, but I also work as a clinical auditor for a lab quality of Finnish small company. As I have been both auditing and auditees from the very beginning of the system in Finland, I will tell you our solution of clinical audits. First, something about the background, then implementation of clinical audits in Finland, outcome, what we know about the service done about the outcome, some ideas of the future development of clinical audits in Finland, and then I suppose I have some time for some personal ideas and views. First, the background about Finland. We are 5.4 million people, sedimented partly to the south, sandwiched between 9 million Swedes and 140-something million Russians. We have a lot of forests. We have many lakes. And we have many radiological units compared to the number of people. So we have 5 big hospitals in Finnish standards, less than 20 biggish hospitals. So that means we have a lot of very small radiological units, the smallest having, let's say, 1 or 2 examination rooms, 1 to 3 or 4 radiographers with a radiologist on site, physically on site once in 2 weeks, once in a month, or even less than that. So the legislation, the basics is, of course, in EU standards, but for the clinical audit point of view, the most important for us was the minister's decree in 2000, very detailed decree. Of course, the regulations given by Nuclear Radiation Protection Authority, in Finnish, Säteilyturvakeskus, a typical Finnish word with 18 letters, so we prefer to call it STUK, as they do themselves. On the clinical audit point of view, of course, all guidelines given by STUK or professional societies are very important. So clinical audit should be, or is, systematic. It's to improve patient care. It uses structured review and, again, as the previous speaker said, against agreed standards. But clinical audit is not regulatory inspection. They have different bases, and also the use, at least in our practice, the use of the result is different. The auditors give recommendations. What the unit does with the recommendations is kind of their responsibility. It's their business. As EU says, all member states are to carry out clinical audits according to their national procedures, and now we go to the national procedures in Finland. The minister's decree stated that clinical audit shall be arranged to supplement self-evaluations of practices. So that's the basics of everything. All the clinical audit is the self-evaluation, internal audits, self-assessment, how do you want to call it? And the clinical audit is to be carried out every 5 years in all radiological units, except the small units with only minor dental imaging. The decree of the ministry was very detailed, and it points out 10 points of interest that should be audited. First, definition authority and responsibilities in the medical use of radiation. Possibility and practices how to refer patients to other modalities which use less radiation inside the facility or to other facilities. Justification process, instructions and practices for the use of medical radiation. Equipment, doses to patients, and the outcome of diagnosis or treatment. Outcome of diagnosis meaning image quality and the impact of imaging to patient care. Quality and flow of information, so PACS systems, risk systems, patient report systems and such. Training of staff, meaning radiation protection training, which is obligatory in Finland, also for referring doctors. Quality assurance procedures, and then self-evaluation of practices. The ministry also set up a national advisory committee to coordinate the implementation of clinical audits. However, after these more than 10 years, it's still very important for us because it organizes the service of the outcome of audits and also gives priorities and recommendations for the audits in the future. This is a list of the recommendations. So the advisory committee doesn't give rules how to do it. They are recommendations. And how we use those recommendations, of course, depends on the practice audited, the type of the practice audited. But they are very practical, these recommendations, are very useful actually for both the organizations auditing as well as the organizations audited. One thing in our system of auditing, clinical audits, is that we auditors, we are professionals in radiology, not professionals in auditing. But the whole audit is based on our experience and knowledge of good practices in the medical use of radiation. Of course, we get education for auditing, but it's limited anyway. The auditing team always has a medical expert, usually a radiologist, but depending on the practice audited, it might be nuclear medicine physician, cardiologist, or so on. For example, I am good at auditing conventional radiology, CT, of course pediatric imaging, but I wouldn't go and audit a unit where mammography is a very important part of their practice because I don't know anything about it. A radiographer or technician, how you call the profession, is always in the team, and medical physicist if the practice includes potentially higher dose imaging like CT or interventions. About 150 auditors have trained so far, but most of them do actually not do audits, but they had the training to develop their own quality systems. So the recommended priorities by the National Advisory Committee, for the first round, they actually didn't give any recommendations. It was more like putting up the documentation of the quality systems already in place. But the second round, the priorities were pediatric examinations, a transfer to digital techniques, which was actually, the digitalization process was about at the end in Finland at that time. Computed tomography, radiation protection training, for radiological staff and the referring physicians, self-assessments. In 2012, so the next round, the third round, the priorities were cardiology and interventions, use of radiation outside the radiological departments like bedside imaging, use of radiation in OR rooms, and so on. New equipment or modalities that had come after the previous round of audits. What we do there, we get the documents we want beforehand, we review them beforehand, quality manuals, instructions, results of self-evaluations, what they have done with those self-evaluations. We discuss them with the staff and with the management inside. Then we interview the staff, radiologists, radiographers, referring physicians or personnel about their practices. And then we observe the practices. Do they follow their own instructions? Is there something that would need more instructions, something that would need, well, new discussions? The radiologist looks at samples of examinations. Let's say 10 abdominal CTs for acute abdomen, 10 pediatric head CTs, 10 pediatric chest X-rays, whatever we choose from one date backwards. And what is audited from this sample is the referral, the quality of referral, justification, the image quality, the images from PACS, the report, and finally also the patient report to see the impact of imaging to the patient care. So the whole process is reviewed. What we know about the outcome. The first survey was done in 2006 when most of the units were audited once. An average of 4 to 7 recommendations per healthcare unit had been issued, and we must remember that recommendation for something doesn't mean that you're not doing well. It means that, hey, we found something that you could develop further. I think recommendation, I think it's a good thing to have. It's a way to improve. So the recommendations were about providing medical physics expertise. That was a bit new at that time. Improving referral practices, improving imaging practices, training, and establishing self-evaluation practices. As you can see here, justification process, it's not a problem, but the quality is of the referrals is. So this means phone calls, and it's time consuming. Quality and assurance, yes. Dose issues like dose measurements, dose levels, might be the use of diagnostic reference levels and so on. Training, meaning radiation protection training and instructions for the use of medical radiation. But it also revealed the need of improvements of the audit practice. We must remember that, especially at the beginning of the system in Finland, the experience of the auditors was quite variable. I came from a certified hospital where I had been doing internal audits for years, and many of the auditors trained at the same time, they haven't heard about the thing before their education. So also what came up was that we need more clinical criteria to avoid the overlap with regulatory inspections. Further development of guidance and training of the auditors, as I said. And some people thought that the audit team should always include an expert physician. At the beginning, there were problems that we didn't get cardiologists to audit all cardiology units, for example. The second review, 2012, asked, for example, about the usefulness or benefit of the clinical audit. The bright green columns there are sadly small, I admit, but luckily the light green ones are the biggest, almost in every aspect except the benefit to cost. Well, if you ask the management, everything in healthcare always costs too much, so I'm not that worried about that one. Improvement of practices due to the audit. The biggest columns being instructions, imaging practices. Well, I was a little bit surprised of this. Self-evaluations. Of course, we don't have this kind of self-evaluation or internal audit bank that the UK has, and that's a very good idea to develop also in Finland. What is very interesting in this question is the communication. Communication between different professionals has been a supplementary benefit of clinical audits. I think it's very important, especially in the small units, but also in big units. You know, in small radiological units in Finland, the radiographers are often the only radiation protection professionals in the whole place, in the whole health center. So when their communication with other professionals improves, I think it improves the whole aspect of radiation protection and patient care. Future developments. What the advisory committee has planned, points of interest common for every unit, like previous recommendations and reactions to them, local priorities or points of interest. For example, in our unit, in our children's hospital, what we have planned to ask the auditors next time when they come is to audit our referrals from intensive care units. You know, we tend to have, during the weekend, those referrals saying just X-ray. And we hope that the word of auditors, outsiders, telling that this is not enough makes more impact than our whining. Then self-evaluations, and especially their effect on practices. What we have also, or actually they have planned, are predefined procedures audited nationwide with specified criteria, kind of what they are doing in Britain, as we heard. So to get nationwide, national data to which all units can compare their practices, their level of quality. What are those procedures? Well, there have been ideas like CT for acute abdomen, CT for pulmonary embolism, colonography CT, pediatric head CT, pediatric trauma. I don't know what it's going to be yet. Good practices are the critical parts for clinical audits. As we know, there are many guidelines for good practice, but they are not so easy to find, to read, and put into practice. as many other countries, we in Finland have done these national guidelines. Of course, we have them in Finnish, except the most recent one, which was actually also translated into English, a very good one, I would say. Then about the personal experience. This is an example of our schedule in part of the afternoon, no, but part of a day in a big hospital. A medical physicist, a radiologist, radiographer, we all went to the pediatric units at that time. The medical physicist looked at quality assurance, dose optimization practices, and discussed them with the local physicists, maybe radiographers. The radiographer looked at the instructions, observed the practice, and discussed instructions and practices with the radiographers, with the staff. I did look at the sample of examinations that were collected. I can see that there were 10 pediatric x-rays and then pediatric body CTs, and the whole process from referral to the patient reports. In a small unit, the day is a bit different. This is scheduled for 2 small units. Before noon, 1 unit, and then another afternoon. First, discussions with management, radiographers, hopefully radiologists, if we can catch one, and interviews, discussions of their quality manual, the instructions, so on, then the observations. And what I want to do is see the images together with the staff. That's a very good place to discuss their practices and their the need of development. Then I also discuss with referring doctors. Then facts and feelings. Okay, as I think that auditor is a neutral observer, but I see my role largely as educational. So the distribution of good practice instructions, guidelines wouldn't have been so smooth without the audits, I think. What I get, they don't pay me that much, but I learn a lot. For a person who has done whole career, my career in university hospitals, it has been very eye-opening to see how they do, in which circumstances they do this work in other parts of the country. What we faced there, at the beginning it was suspicion, sometimes even hostility, wariness. What are those people to come here and tell me how to do my job? They don't understand our circumstances, but it has changed. And nowadays we get friendliness. People are very curious. They are very eager to show what they have been doing. They are proud of their profession. They are eager to learn more. So, some references. Thank you for listening, and thanks to Hannu Järvinen again.